Welcome to iHF. Today we discuss of novel fast-track strategies to guidelines-directed medical therapy optimization in heart failure patients with functional mitral regurgitation. These are our objectives today. We are here to understand together how percutaneous mitral valve intervention, MTR, demonstrated step-by-step can enable a fast-track GDMT optimization, to appraise the impact of biomarker-guided heart failure therapy, and to learn how to effectively and safely implement and up-titrate GDMT. Of course, I cannot do this alone, and with me here I have a great team. Sabine Bleitziffer, cardiac surgeon from Germany, Philipp Lurz, interventional cardiologist from Germany, Alexandre Mebazaa, intensivist from France, and Giuseppe Rosano, heart failure specialist from United Kingdom. This is us. Tell us now something about you. Please answer this first poll. There will be several others along this webinar. And tell us what is your specialty expertise. And if you don't find yourself listed in any of these categories, just type in the chat box what is your field of interest and expertise. With this, I think without further ado, I'd like to hand over to Philipp Lurz, who's introducing us the case. Thanks, Philipp.
Thank you. So in the following, I would like to give you a summary of one of our patients, a patient who has been known to have HFrEF for quite a long time, secondary due to ischemic cardiomyopathy, and this was caused by severe three-vessel coronary artery disease, and he also had a recent intervention in his left anterior descending artery. He also had underwent ICD implantation, and he is known to have relevant degree of mitral regurgitation. He recently came to our attention because his clinical condition deteriorated. He was still ambulatory, but really highly symptomatic, very limited in his daily routine, NYHA class 3 to 4. He had an increase in NT-proBNP, and this is also important, also in the moment when we talk about his medication, he has had several episodes of hypertension, and this was also well documented on an ABPM showing both low values for systolic and diastolic blood pressures on a 24-hour mean. As you can see here, the medication of the patient can certainly not be considered as optimal in a patient with HFrEF. You see that the beta blocker is given only at very low doses. There is a low dose of Entresto. There is no MRA and also no SGLT2 inhibitor. There was at least one failed attempt to improve his medication, and the reason why it failed was due to symptomatic hypertension. The ECG showed that there is still sinus rhythm, there is some degree of repolarization disorder, and this is certainly important for further treatment options, there is no significant widening of the QRS. Transthoracic echocardiography showed that there's reduction in left ventricular ejection fraction. You can see that almost all segments are dyskinetic, maybe a little bit better functioning at the basal segments, but overall certainly severely impaired left ventricular ejection fraction. The right ventricular function can be considered still reasonably preserved. And as you can see here already, there is some degree of mitral regurgitation, as we almost always do in these patients, especially when the clinical situation deteriorates, that we also add a transesophageal echocardiogram to quantify mitral regurgitation. You can see there is a long axis and a short axis, and as often in these patients, the vena contracta looks smaller on long axis, but only if you consider and assess thoroughly the long axis as shown on the very left on the screen, you can see that there's really a wide vena contracta, and overall this mitral regurgitation was graded as severe. And with that, back to you.
Thank you very much, Philipp. Sabine, just to inform you on the result of the poll, most of our colleagues connected are heart failure specialists or clinical cardiologists, evenly distributed. There are 20% of our colleagues are interventional cardiologists, 5% are cardiac surgeons.
Great.
And under the other category, there are the remainders. So,
Yeah.
back to you.
I would say thank you, Philipp, for the nice case presentation. And I think it's time now for some decision making. And that's why we would like to ask you a second poll. What would you suggest to do at this stage now? And you can choose adding intravenous diuretics, adding SGLT2 inhibitors, adding both 1 and 2, upgrade to CRT, or other. And I think with this we can discuss within our team what could come next.
So while they are voting, I take the opportunity to kick off, perhaps Giuseppe. So let's summarize. I took some notes here. So we have a patient, relatively young, 62 years old, 63 years old, with worsening heart failure. He came, as a matter of fact, in acute heart failure decompensation. Low ejection fraction was something around 20-25%. Severe mitral regurgitation. Systolic blood pressure was less than 100. Heart rate was less than 70. What are the available options there? What would you do in this case?
Now, there's a clear indication for the 4 pillars. I understand there are problems with maintaining a good blood pressure, but also the patient was on sacubitril valsartan and not on the SGLT2 inhibitors and the MRAs. So in theory, I mean, this is a patient where we should have revised and tried maybe to reduce or go back to the ACE inhibitors and give the MRAs and the SGLT2 inhibitors. MRAs and in post-ischemic, especially eplerenone, they have a specific role in these patients. They reduce events significantly, they improve function. So I think there was a little room for managing the different treatments. Also, metoprolol was around 50 milligrams BED. In patients in sinus rhythm, you may try to reduce the metoprolol and give it together with avabradine in order to give the few millimeters of mercury that then will enable you to implement all the other therapies. So there is a little, that you can do, but of course, even with the full foundation therapy, there is a clear indication for intervention on that mitral valve.
So just help me out in understanding, if this was my patient, what would have been the drug to choose first if I couldn't give all of them, the 4 of them together? Is there any algorithm that you follow, any priority?
Yeah, we follow the patient profiling that we've suggested a few years ago, where we give according to the different profiles, so based on heart rate, blood pressure, renal function, sinus rhythm, atrial fibrillation, the indications on how to optimize according to how these different parameters combine.
Great. Alex, now this patient is a young patient, according to the standard we use in our practice around in the 60s. Would you have changed anything in your therapeutic approach if this patient were to be 80 plus years old?
Yeah, thank you, Emanuele. It's a very important question. It's in fact a daily question in our units. Now, I don't know what Philipp would have done if the patient is 8 years old, but please keep in mind that if the patient is 8 years old, he's in good shape with all the parameters that we heard, he should have exactly the same treatment.
That's right. And now to you, Sabine. We spoke about drugs. I want, of course, ask you about interventional percutaneous therapy. What about surgical options in this patient?
Yeah. So this is a young patient. He's not super high risk, so he should definitely be discussed in the heart team and to take into consideration all options. He has no indication for any other cardiac surgery, so this would be the decision or the first thing which would be discussed would be interventional TEER therapy. But if the expectation would be that the reduction of MR could not be very effective, still surgery could be discussed with a greater expectation to reduce the mitral regurgitation.
There's one of the question here regarding resynchronization therapy. I'm sure we will hear about that shortly, but perhaps we can answer this question by sharing the results of the poll in the meantime. So we have 10% of our colleagues who would have added to the therapy intravenous diuretics, Philipp, to your patient. 22% would have added SGLT2 inhibitors. Majority, 44%, would have given both options. No one would have offered to this patient CRT for obvious reasons that we will discuss in a second, and 22% would have other options. Of course, there is no room here to understand what the other option would be. To the colleagues with other option, you have the opportunity to type in the chat box what the other option would mean for you. Sabine, what's next?
I think now this is the moment to go back to Philipp Lurz to hear how things were going on.
All right. So I totally agree that despite the fact that he might be hypotensive when adding too many drugs, there is something which could be optimized in that patient. That was the medication he came with, and that's just the reality. And it's not rare that patients are put on Entresto, but not on an MRA. But that's just the reality we are facing. Obviously, the question here is, could we have done a little bit better in terms of drug treatment? But he had already at least one failed attempt to improve it. And our overall impression was that without improving the patient hemodynamics, GDMT will not be optimized in a significant way. And the easiest way to optimize hemodynamics is to treat the mitral regurgitation, which was clearly quantified as severe in that case. And CRT was not an option because the QRS duration was not within range for a CRT. So treatment decision in the heart team was to go forward with an M-tier procedure, so a mitral tier procedure, which stands for transcatheter edge-to-edge repair. So obviously this is non-surgical, minimal invasive, and that procedure requires an access normally in the right femoral vein, and then the system is advanced after a transeptal puncture into the left atrium. And through the guide, then a clip can be advanced, and that a clip can be steered with a system which has multiple knobs on it, which allows steering in the three dimensions of freedom. And this clip is then orientated in the exact way in the left atrium. And then after the clip is positioned pretty much on top of the regurgitant jet, the system is advanced through the valve into the left ventricle, and then by pulling the clip into the leaflets will come to be situated on top of the clip is placed, and thereby the two leaflets come together, and ideally the degree of mitral regurgitation is reduced. Now, conceptually, sometimes this therapy is misunderstood. What we do here is we do a leaflet therapy, but as said, this is secondary MR. So it's not a problem of the leaflets, it's a problem of the annulus. The annulus is dilated. So, and if you do a surgical repair, obviously you have to address the annular dilatation. And interestingly, although it is a leaflet therapy, we do address the annular dilatation by performing TEER in functional mitral regurgitation because, and this is illustrated now in this cartoon on the left, by bringing together these two leaflets, we also pull on the annulus, and this causes a reduction in annular dimensions. So this is a leaflet therapy, but we get an indirect annuloplasty effect, and this is, at least in my mind, the reason why it works not only well when you have leaflet pathology, but also in functional secondary mitral regurgitation. Okay, the procedure is pretty much echo-based with a bit of fluoroscopy. The first step is performing a transeptal puncture in the left upper panel. You can see that there is a so-called tenting, so the needle is pushing against the intraatrial septum, and once the correct position is affirmed, then the needle is pushed through the septum, and then...
Allow me to interfere here, just for my understanding. What I see in the upper left, in the chamber that is underneath there, that is the right atrium, right? And what I see pushing there is the needle that is trying to enter the left atrium.
Is that
correct?
Absolutely. So obviously we come from the right atrium and we want to go into the left atrium. In the right upper panel, you can see already the system coming from the left atrium into the, from the right atrium into the left atrium. And then multiple views are used, as you can see also in the left lower panel, a 3D orientation and visualization of the overall anatomy, which is normally sufficient to very safely do the transeptal puncture, and then position the system in the left atrium. The next step, and in between also fluoroscopy is used as illustrated here. The system is then positioned, and in this case there are two systems available, either the MitraClip or the Pascal. Here we use the Pascal, but both procedures have the same principle and work very similar. The system is orientated in a pretty much 90-degree orientation in respect to the mitral annulus, because this allows a quite safe and straightforward procedure. The device is then opened, and also something you can see in the left panel, while still being in the left atrium, just on top of the mitral valve, and then, and this is shown in the right upper panel, on 3D echocardiography, one makes sure that the clocking of the device is orientated and aligned towards the line of cooptation in a 90-degree fashion, because obviously what is important, by connecting these two leaflets, we certainly do not want to distort the overall anatomy of the mitral valve. That's something which is very important for these procedures. Next step is then crossing the mitral valve, and then after crossing, the device is pulled into the leaflets, and once the leaflets are situated just on top and pushing against the device, the so-called clasp or crippers, depending on the system used, are brought down. This is again illustrated in the left lower panel. These crippers or pedals are then brought down, and thereby the leaflet is grasped in between, and then the second step would be to close the system. Before closing, once again illustrated on 3D echocardiography, on the top it is made sure that the so-called clocking is correct, so 90-degree towards the line of cooptation of the mitral valve, or in short, is 12 to 6 o'clock orientation of the system, and then the device can be closed. Now, what I would like you to focus on here is how the anatomy does change. What we see here is again a 3D appreciation on echocardiography of the anatomy while the device is closed. And we see that the device is closing now, and I hope that you can appreciate that the anatomy comes together. And this is what I meant before, that indirect annuloplasty effect. So by connecting the anterior and posterior leaflet of the mitral valve, the annular dimensions become smaller, and this is why that procedure is effective. Okay, so we have done that, and then obviously we press on the echo machine the color button. This is where it becomes interesting, and then ideally we would like to see almost no residual mitral regurgitation. We would accept mild, but we don't want to have moderate, only in extreme and bailout cases, but normally we would like to bring it down to mild. And once this is assured, then the clip is released, or the Pascal is released from the system. This is illustrated on the right lower panel on fluoroscopy. So there are some certain buttons which can be pressed on the system, which releases the Pascal, and then everything is fine. What should be mentioned is, what we don't want to have a perfect result in the cath lab and then be disappointed the next day when the patient is in the echo lab. So normally we make sure that the patient has an adequate blood pressure before release, and we only assess mitral regurgitation with normal or supranormal blood pressures, just to make sure that we won't be disappointed, and most importantly, that we won't have a suboptimal result for the patient because we are misled by low blood pressures and therefore low mitral regurgitation. That was the final result. On 3D echo, again, we see a nice tissue bridge between the two leaflets. We see in blue the inflow, which is certainly laminar, means that there's no gradient, we have no turbulent flow, and we see a tiny cloud of red. This is the degree of residual MR, which was graded as mild, and as said, this is the treatment goal, so we were happy with that.
Thank you very much, Philipp. Really, that was, I learned a lot. I learned a lot with this step-by-step approach that you guided us through with your patient. And I have a number of questions, of course, because these raise a lot of interest. There was one colleague that was really a funny question, but I can understand it because we have quite a heterogeneous audience out there. Is asking, where is this procedure taking place, in the echo lab or in the cath lab? As a matter of fact, he saw most of your procedure illustrated through echo images. Perhaps we can discuss a bit the role of non-invasive imaging guidance in this particular procedure, Philipp.
So the procedure is performed in the cath lab or in a hybrid OR, ideally in a hybrid OR. And obviously it is minimally invasive, but it's not something which is done in the echo lab. But as you have seen, echo is the key to that procedure. Fluoroscopy adds a little bit, but it's really all about echo guidance, and it requires a good collaboration and communication and interaction between the operator and the echocardiographer. So I would say that the echocardiographer is at least and maybe more important than the operator. The operator just turns a couple of knobs and does what the echo person tells him.
Which is really the example of multidisciplinarity into action and into practice. Perhaps we can display the third poll of our webinar. If you can pop up the several options, just to understand a little bit what is the practice of our colleagues. So you've got 4 options. Option number 1, M-tier is not available in your institution, and therefore you do not consider at all this option for your patient. Option 2, M-tier is not available in your institution, therefore similar patients are regularly sent to a partner hospital. Option 3, you do have M-tier available in your institution, you do have colleagues performing M-tier like Philipp, but still you do not think this is the right patient to offer this therapy. And option number 4, M-tier is available in your institution, and much like our colleagues from Germany, you would have done this procedure in this patient. Think it over, respond to this poll while I'm a little bit getting some experience from Philipp, first of all, because we need to address additional question here from our colleagues. Technical question, Philipp. How do you basically tailor your interventional therapy and your results? In other terms, we always need to put one clip. Are there cases where you want to put additional clips? And when do you stop and make yourself happy about the result?
Yeah. So in most cases, we would implant 2 devices in functional mitral regurgitation. In this case, 1 device was sufficient. Obviously, we always start with 1 device, and then the decision whether it requires a second device, there are actually 2 reasons for that. Either because we aren't happy with the degree of reduction in mitral regurgitation, and if it's still moderate, and if it's still the impression that it can be reduced, then we would implant a second one. And then the third reason why we would implant a second or even third device, and this is more difficult to decide, and that's something we still learn, is considerations about the longevity of the result. So in some really large anatomies, when the annulus is really severely dilated, we would implant a second or third device, irrespective of whether of the amount of residual MR, just to make sure that, under the assumption that the longevity will be improved by more devices and thereby more stability.
Sabine, we heard about the percutaneous option, but after all, this is a young patient, 60 years old. Can you tell us about the surgical options that we can offer to this patient, but this time really going more into details? I want to know exactly what you would do if we were into your operating theater.
Okay. So for primary mitral regurgitation, it is clear we will try to repair all valves. For functional mitral regurgitation, it's a different story, and the main goal is, of course, that the patient leaves the OR with MR 0. And the younger the patient is, the more I would also try to repair the valve, but not force it somehow. What we do is we stabilize the annulus with an annuloplasty ring, most semi-rigid or rigid ring, so that this stays in shape and size for long term. And but what we also have to do in functional regurgitation is to repair, to do a subvalvular repair in the ventricle. That means to resuspend the papillary muscles and bring the leaflets into the annular plane again, and to have a coaptation area. So when this does not seem reasonable, especially if the posterior leaflet is extremely restrictive or extremely short, I would be very generous to decide for a valve replacement, because with a valve replacement, I know the patient has a 0 MR for a long time. This will, if it's a bioprosthetic valve, this will last for 10 to 15 years. And also, we have not seen a survival benefit indeed for the functional MR patients with the repair, but a recurrence rate of up to 30% at 2 years.
Philipp and Sabine, actually to both of you, we've been always teased by our friend cardiac surgeons that the final result of our percutaneous valve interventions is always suboptimal. It's either because there is a little bit of paravalvular leak, or there is a little bit of a residual functional MR. By the way, the final result of Philipp was just excellent. I haven't seen much of MR left. Does it really matter, Philipp, the final residual mitral regurg? And if it matters, what is the extent to which we should care about it?
It seems as an easy question, but it's actually not. It's quite difficult to answer. I mean, obviously, we always want to try to reduce it as much as possible, but it isn't as clear in the literature to state what degree of MR reduction we have to achieve. And actually, the only study so far which has proven that a reduction in functional MR is beneficial in terms of hard clinical endpoints is COAPT, and that was a percutaneous transcatheter approach study actually using MitraClip. It makes sense to use whatever is available and possible to reduce MR as much as possible, but it's not that clear yet. You have to bring it down to at least moderate, but the current gold standard and treatment goal is to bring it down to mild and less.
Sabine, one colleague is asking, wasn't this procedure initially a surgical procedure, this stitching of the valve? And if so, are you still using it? Are you still doing this Alfieri stitch in your practice?
So indeed, the tear mimics formerly surgical procedure. But this was always used indeed as a bailout procedure, and it still is. So if you do a good repair, you don't need an Alfieri stitch. So it's only a bailout procedure and used quite rarely.
But if I'm not mistaken, that Alfieri bailout stitch was something to treat a problem of the leaflets, right? But it wasn't done in a way that the annulus comes together as much as we do it these days with clip. And I think this is the conceptual difference, that yes, it is a leaflet therapy, but we really pull hard to get the annulus smaller, and that's something which has not been done with Alfieri.
Yes, but if we do surgery, of course, we can do the annuloplasty, if you are there.
That's an interesting discussion. Let me take the discussion away from the surgical theater and the cath lab. Let me go back to the clinic. We heard about percutaneous indirect annuloplasty. I like very much the concept of Philipp. But how long does it last? After all, that's not just a valve disease, that's a cardiomyopathy here. It is of interest for the ventricle. Any experience, any thought on that?
Yeah, and I think Philipp was saying this earlier. This is really the bridge to go to the real chemotherapy, to really GDMT. But as you said, I mean, they did a great job. One clip, mitral regurgitation was markedly reduced. Now we are just waiting for the pressure to go better. For sure, the patient is going to breathe better. I mean, I'm sure Giuseppe would agree. Probably quality of life already would have improved. But again, we should not be fooled by this improvement in quality of life. We should give GDMT.
That's very well said, but before getting there, I would like to share with you the results of the last poll. So, majority, 50% of colleagues do answer that they do have mitral tear available in their institution, and they would have performed the procedure much like you did in your center, Philipp. And the remainders, well, actually 33% would not have mitral tear in their institution, but would have sent the patient regularly to a partner hospital, and 17% of the colleagues, they just said no, in the sense that they don't have M-tear, they would have not considered this option. So we have to keep in mind that there is also this practice out there within our communities. Now, I know, Alex, that you did a very good job, a very good work, and you have excellent data on the immediate follow-up of these patients after discharging them from the hospital. Now, the intervention has happened. What comes next? How should we optimally follow up this patient? But before giving the word to you, I'd like to launch the next poll so that colleagues will have time to reflect on that. This is the next question to you. How do you follow up these kind of patients in your practice after hospital discharge? Option 1, I see them 1 month after discharge and then every 6 months. Option 2, I tailor follow-up visits depending on the clinical status and blood tests. And option 3, I see them often, every 2 weeks in the first 3 months after discharge, then less frequently. Alex, back to you. Share with us the data you have produced.
Yeah, thank you very much. I really like very much this case because the team of Philipp did the bridge. And we should think, even by the way, when the patient goes to surgery and the annulus is reduced, we should think that, okay, we did the maneuver, but the ventricle is the ventricle, and we didn't, probably we improved a little bit, indeed, by the occluding the mitral regurgitation, but the ventricle is almost the same, and we need to treat the ventricle now, whatever is the intervention. And it's true that now it's time to go to GDMT to really improve patient condition and, more importantly, to improve outcome. Then the question is how to optimize heart failure therapy, and then we will talk about biomarkers. In fact, what is happening, and this is what happened in the case, the patient came with a pulmonary edema, he was fatigued, he was clearly in acute heart failure, and for years, indeed, these patients were treated just with a little bit of diuretics, a little bit of oxygen, and those patients were named frequent flyers because we were seeing them again and again and again. And in fact, as we can see in this scenario here, the patient are discharged, and the only hope for them is to hope to not come back, but unfortunately they come back. And it's really a paradox because today we have chemotherapy for heart failure. We have the treatment that can really save those patients. We know that if we give the 4 pillars, ACE, ARNI, beta blocker, MRA, SGLT2, if we can achieve for the 4 pillars to have the target dose, the optimal dose, and if we can give them together, we can markedly prolong life. And as Giuseppe was saying earlier, not only we are going to prolong life, but we are going to prolong life with a good quality of life. And this is really something that we should keep in mind. Now, however, in all the pools and all the surveys done anywhere in the world, including in a Scandinavian country, although the results of the northern country is really better and better, we still have many patients who do not have the 4 pillars, at least not at the optimal target dose. And to try to convince our colleagues that really when the patient is coming with an acute heart failure, raising again the red flag, telling us that I am not well treated, we thought to do the strong heart failure protocol. And this protocol is rather simple. Before the patient is discharged, we're still in the hospital after this acute heart failure episodes. Before his discharge, we would give him, together with diuretics, we would give him half of the dose, optimal dose of ACE and or ARNI, together with half of the dose of optimal dose of beta blocker and half of the optimal dose of MRA. And sometimes people are asking me, but are you really giving them together? Yes, we were giving them together in the morning at the same minute. And then the patient is discharged. And maybe we'll come later on how we manage this patient. In fact, this patient enters in a VAP path, meaning that when they are discharged, we are going to see them frequently until we achieve the full chemotherapy, or at least the highest dose we can achieve for those patients. In strong, the target was week 2 to have a full heart failure therapy. Now, we achieved this. If you can see here on the blue bar, those are the patients treated in the usual care arm, meaning by the cardiologist in town. And the red was the high intensive care arm, where really we pushed the cardiologist to try to give the optimal dose. And you see that for at least ACE, RB, and ARNI, and beta blocker, you see that 3 to 6 months after discharge, again, a patient coming with congestion, you see that for the blue arm, it's less than 5% to close to 5%. And in our high-intensity care arm, we could achieve at least in half of the patients the optimal dose, and it's even more spectacular for MRA, higher than 80%. Now, the question that isn't often asked is, but Alex, if you give all those chemotherapy, can you translate to a better outcome? The answer is yes. You can see here that if in the high-intensity care arm, we can reduce in few months, clearly at 180 days, 6 months, we can markedly reduce readmission and death, hospital heart failure readmission and death, And I think there is no discussion there. But our big surprise, and really this is something I learned from Strong, is not only we are improving and preventing heart failure readmission and improving survival, but we discovered that without giving any indication to the investigators, they gave less diuretics in the high-intensity care arm. And despite having less diuretics, as you can see here, all the metrics, with no exception, of a better decongestion were all improved. And this is only 3 months after discharge. And 3 months after cutting all the neuroendocrine system, you can see that all the metrics of decongestion were there, and this is really something we learned. Another point another question that is often asked is, Alex, but if we go to 50%, 50 to 90, I mean, 75 is already high. You say, no. We should really go to 90 to 100% if you can. Indeed, some patients you can't, but if you can, try to push your 4 pillars to higher than 90%, meaning almost 100, 100, 100, 100. Why? Because it's going to be associated with a better primary endpoint, mortality and readmission. And even you see on the lower panel, mortality and survival is improved if you give the toppest dose. Now, based on these recommendations came out in 2023, I think they are clear, and a strategy of initiation and rapid up titration, the 2 words are important, starting before discharge. And we have data to show that really there is even a psychological effect when the patients start to have those medications before being discharged. We need to give several follow-up visits, ideally 6 weeks. Now in some countries they may go to 8 weeks, but really we should go as quickly as possible and have a VIP path for those patients who come with an acute heart failure. What we learned from the guidelines is all the task force said we need and we can add SGLT2, then really the 4 pillars can be initiated before discharge and really up titrated for the 3 pillars that are not SGLT2 after discharge. For every visit is easy, very easy. You just need to look at 6 signs to make sure that this intense implementation of the heart failure therapies are safe. Signs and symptoms of congestion, blood pressure, and heart rate. Those are the 3 clinical signs, and 3 biological signs. NT-proBNP to check that congestion is really improving. Potassium and eGFR. Very recently in Harvard, the team of Jim Januzzi and Afrodita Spahilari, she did echo before and after the Strong procedure, and she could show that there is a clear reverse cardiac remodeling. Ejection fraction is improved. You may not be impressed, 6%. It's better than nothing. But see the volume. All the volumes of the left atria, the left ventricle were reduced. And then we come back to the MR. You can see clearly in this paper that MR was markedly improved. And I'm sure in your patient would have been even a greater benefit. Then clearly the message is before discharge, please start glyphosine, diuretics, half dose of ACE, ARNI, beta blocker, and MRA. And when the patient is discharged, VIP path, you see them with the nurse and you do everything to go to full therapy. Thank you.
Thank you very much. Thank you very much, Alex. Let me just share with you the results of the poll. Your paper was out 2 years ago, I guess, 2023, and the guideline recommendation a little bit after. But actually, it was already impactful, as majority of colleagues answered option number 3. So in general, I see them every 2 weeks in the first 3 months after discharge, and then less frequently. And the remainders, they tailor their follow-up visits on the clinical status with blood tests, which makes also a lot of sense. So that's what we get from our colleagues. But let's move one step further. And the first question goes to Philipp. After performing the M tier, how quick do you see the improvement in hemodynamics? Does it take hours, minutes, days? How quick do you see that?
It might take hours, but then obviously in the post-procedural course, it is slightly turbulent and more difficult to assess. But on the first or second day after the procedure, sometimes it can be seen already that there is a hemodynamic improvement. We don't have them too long with us in the hospital. We discharge those patients 1 or 2 days after the procedure, but obviously not before we, also in this case, try to improve heart failure medication, and then we follow them closely. But normally the hemodynamic improvement kicks in very early, but then ideally improves even further over time.
Just by way of curiosity, do you have any insight in strong HF of patients who underwent also M-tier within your group? Do you
No,
have
we did not analyze this.
But that would be interesting to know whether there is, a kick, an additional speed up in catching up with the hemodynamic improvement with a combination of interventional therapies and heart failure therapy.
And I think the comment that Philipp is making is very good, because you saw that at least in the first 2 weeks we could optimize the treatment only in 50% of the patients. And I'm convinced that among the 50%, exactly like in your case, where we could not titrate, we should have gone to plan B. It was not planned in the protocol, but clearly what you are showing is clearly plan B should be the option.
Giuseppe, how do we have to evaluate this hemodynamic improvement? How can we monitor best the left ventricular function improvement? Is it something we have to do by cardiac MRI, by echo? What is your practice?
Usually, it's better to assess patients by means of congestion. And what Alex showed in strong HF is that the NT-proBNP is the best way to follow these patients. I mean, the echocardiogram will improve, the left ventricular function will improve, the volumes will improve, but then what matters is the degree of congestion, and that also is important, as shown in the strong HF. It matters for the implementation of different therapies, especially for those patients where you are thinking of implementing the beta blockers. So that is probably the key. I would use more the NT-proBNP than the echocardiogram.
Did you want to add anything?
I would like to make a strong argument for the procedure, in that one should trust the procedure. And if one is able to reduce MR to that extent, I wouldn't be bothered in measuring hemodynamics too much, but just trust that it's better now. Add a drug class or increase the doses, and in most cases you will see that up-titration is now possible. I don't think we have to measure it too much, but then be confident enough, try it. There will be some rare examples where obviously patients will come back hypotensive, but it is much more likely that GDMT up-titration will work after such a procedure.
Yeah, if I make a small comment,
yes,
again, don't be fooled by the clinical signs, because in those cases, the patient feels better, and he will tell you, but why do you up-titrate while I feel better, while M-tier is better? I'm sure, Philipp, it's the case of your scenario, and really we should be careful. Yeah, he was improved, but there is chemotherapy for cancer. I mean, he should have the full chemotherapy to have his left ventricle and his heart being improved.
Why don't we go back to your hospital and to your case and see how it ended up?
Yeah, maybe before I give you the final development in that case, I would like to remind ourselves that normally, and also myself as an interventionalist, we are told to wait for that procedure until GDMT optimization has been successful. And that should be done several times, and you can lose weeks, you can lose months. But then on the other hand, we have strong HF, which taught us that we have to be as fast and as rigid and as optimal as possible. So it probably doesn't make sense anymore to think either intervention or medical treatment. And that was particularly our approach here. We performed the procedure to reduce MR, but mainly to improve hemodynamics, and then sequentially, hopefully being able to optimize GDMT. We were very happy with the outcome of the procedure, but that doesn't matter. It's all about the patient perspective and the patient clinical situation. But that also improved. He had less symptoms, blood pressure were higher, and so there was a clear suggestion of better hemodynamics. So 4 weeks after the procedure, he came back, was clearly better off. His NT-proBNP was lower, and the fact that the hemodynamics were better is also documented on ABPM, showing now higher values for both systolic and diastolic blood pressures. Here we see the follow-up echocardiogram. Maybe it's important to mention that once again, it is important what we see post-procedural is still in the hybrid OR, but it really matters what we then will see in the echo lab when the patient is awake without general anesthesia. This is the final truth, and here, obviously, we were quite happy to see that the good result in the hybrid OR was also documented then awake in the echo lab. No gradient and no relevant residual mitral regurgitation. That's the course of NT-proBNP, which when the patient had his clinical deterioration clearly went up, and then after the procedure, but then also some changes in medication, it came down and was then lower than at the initial presentation over the course of this patient. And here finally we come to the critical point of this case, why we wanted to perform the procedure. You can see that we were able to increase beta blocker, we were able to increase Entresto, but most importantly, maybe we were able to add some drugs, spironolactone, but also SGLT2 inhibitors. And that together with the MR reduction, but certainly also the GDMT optimization should explain the improvement in the clinical course of that patient. Maybe another comment, because it was asked before, longevity of the treatment. From a procedural point of view, the most important predictor for long-term outcome is the acute outcome. So when you have a good result acutely, then you're more likely to have a good result during long-term. But that's only related to the procedure. Overall, what matters the most is whether we can stop the pathology of the left ventricle. Irrespective of what you do, and I would argue even with surgery, irrespective of what you put in there, when the ventricle further dilates, then it won't work. So we do the procedure to reduce MR, to optimize GDMT, and these two things should help the ventricle not to dilate any further. And if that's achieved, then also the procedural or surgical results are maintained over a long time.
That's very well said, Philipp. We've got many questions to answer here, so there is still a lot of work to be done. The first one is for Philipp, and it is a technical and a legitimate question. You know, to get to the mitral valve, you poke a hole in the atrial septum. What happens to these iatrogenic interatrial shunt that you create? Does it close by itself? Is it of any hemodynamic concern?
It closes in 80% of cases. In 20% it remains open. We actually did a randomized study and closed these holes in one group and left it open in the other, and it didn't do any difference. What's sure is that the persistence of a shunt is a surrogate for higher left ventricular filling pressures, of higher left atrial pressures, so a surrogate for more advanced disease, and that's prognostically not favorable. But closing it, unless you have significant right ventricular volume overload, won't change the prognosis there.
Next question is kind of a touchy question that would affect both of you, Sabine and Philipp. But let me start from Philipp, but I want to hear Sabine on that. Some of our colleagues, if you remind, they do not have such an advanced interventional programs, and they say, I don't have cardiac surgery here with me. Can I still do mitral valve interventions percutaneously in my hospital, in my cath lab, without surgical backup? And next question is, where do you normally follow this patient up after the procedure, on the CCU or on the ward? I would give the word to Philipp and then to Sabine to be completely even here.
I think it's better to do these procedures at a center where you have cardiac surgery. It is very safe, but having said that, there's always the possibility that something could go wrong, and then the outcome might be better if you have cardiac surgery. What is absolutely mandatory is to discuss the patient before within disciplinary heart team. You might not need to have cardiac surgery on site, but you need to have some collaboration with cardiac surgery to discuss these patients.
Sabine.
So indeed, there is not so much to add. In Germany, it's allowed and legal to do mitral clip or TEER procedures also in centers without a surgery, but it's mandatory to have a heart team discussion about all patients. And the procedures really are safe, so I cannot remember any case during the last years where we had to do some emergent intervention, surgical intervention.
One question to you, Philipp, from our friend here. Why was this patient kept on DAPT and not on low-dose aspirin? I recall that this patient had an acute MI a few months back, or did I recall wrongly?
He had an intervention. He had a stent placed in the LAD. Yeah.
And that was the reason for that. Okay. Then next question is about the heart failure clinic. So we discussed that these patients need to go through medical optimization and close follow-up. But how is it structured, the heart failure clinic, at your center. And I want to hear everyone here because I'm not sure we have the same kind of organization. You're practicing in France. Alex, we start with you. How does it work with you in Paris?
We are lucky. We are lucky because since few years now we have heart failure nurses that are specialized. There's 2 years of training. And now more and more, and I can tell you, it's really the future for heart failure management is to leave as much as we can to the nurses who have a clear protocol. But maybe even more importantly is now we have like a VIP path for those who came with acute heart failure, because when there is acute heart failure, really they need clearly it's a sign to go quickly on a major increase in therapy. But heart failure clinics is changing the outcome of the patient. The nurses have more time to discuss with the patient. It's really great.
Giuseppe.
I mean, we are very privileged because first of all, we have a great heart failure unit has been developed by Lisa Anderson. I have to give full credit to her work. And we have the heart failure nurses, without which we cannot work, and the community heart failure nurses. And all this network works together in order to enable a strong follow-up as much as we can.
But practically, Giuseppe, can you describe for me what are the heart failure, and I will explain you in a minute why I'm asking this and why am I so curious. What are the tasks that a heart failure nurse has practically, really, on a daily basis?
I understand that these nurses can do different things in different countries in Europe. In the UK, there are nurse prescriptioners, so they can prescribe. They can up-titrate therapy by themselves, so you often the nurse or the community nurse up-titrates therapy when patients are home. So it's a completely different from other realities, other regions or countries in Europe where nurses can just report on the parameters. So this is why I think we need to unify the role of nurses across Europe, because they're incredible help, and without them, I mean, we cannot, the heart failure team and the heart failure unit cannot just work.
Of course, Giuseppe is a heart failure specialist. He's the best place to teach us how to do that. But let me hear the opinion of two interventional persons here. So an interventional cardiologist and cardiac surgeon. I'm not sure you have the time to go to the heart failure clinic yourself and supervise heart failure nurses. How does it work, the organization in your center, Philipp?
Yeah, it obviously depends very much on the patient, but in such a scenario, we would see the patient back with us very soon, and then we have to make a decision whether he would come to the heart failure clinics or to the valve clinics. But either way, I mean, the procedure is clearly decided under the protocol is clearly decided on already in this discharge letter. The whole team knows what needs to be done, and then it's either the heart failure clinic or the valve clinics.
And do you also have heart failure nurses taking care of your patients?
Yeah, I'm very familiar with such a system in my previous institution, and it is the best thing, and it is really a great thing for the patients, and every center should have that. We are still in the process of building it.
So we see there is already a range of practices here, from very lucky person to maybe lucky in a short period of time in the near future. How lucky are you in your center, Sabine?
I can add more confusion to this because so we have a really big heart failure unit within our surgical department, taking care of those patients who take the path towards ventricular assist device and heart transplantation. Patients like yours who have a valve lesion, who have this as a final or a bridge to something therapy, they will take the path through the valve clinic and also have their follow-up for some time from the valve teams.
Yeah, so now it's the moment for me to share my practice back in Rome. We do have a heart failure unit that is taking care very well of our patients after hospital discharge, but it is not at all well structured like your experience, Alex and Giuseppe. We do not have heart failure nurses. It's not really in the culture and in the organization of my institution to have such a freedom of operating to the nurses, but I think this is the way to go. This is the way to go and try to uniform this pathway of care for our patient. We are still not yet done because people here is interested to know we do see patients very often at the beginning, but when can we start reducing the frequency of follow-up in this patient, Alex? I mean, do we have to keep them following every 2 weeks forever, or is there a moment where we see them, let's
In fact, I would try to answer two questions. Should we see them quickly or not? And maybe it's, by the way, one of the questions to Philipp for his patient. I'm sure we all agree that probably this patient should have been seen earlier, and he came a little bit late. And then your next question is, after discharge, how frequently we should see them. The way I see it is, again, I'm sorry, but look a little bit like chemotherapy with cancer. If the patient is fully treated, I'm just asking a question, why do we see him more than once a year or once every 18 months? He's fully treated, has no symptoms, NT-proBNP is down at 200. We should really leave those spots to the patients who come from an acute heart failure. Because at the end of the day, there's a logistical issue, then we better keep those patients out, except if there is any issue, and focus on really the beginning of the story and try to implement those drugs.
Our colleague here has a question that I'd like to direct to Giuseppe and at the same time afterward to Philipp. Would it have made sense to add SGLT2 inhibitor from the very beginning? Because we saw it appearing at the end of this path. Any room to have it initiated at the beginning of this path?
As I said earlier, without saying that this was not a candidate for MTR, I mean, that would have been a candidate anyway, because left ventricular function would have improved at a level such that you would have reduced the indication. I mean, there was indication for starting the SGLT2 inhibitors, but also the MRAs. I mean, we too often forget the MRAs. I mean, they are the single most important intervention because they reduce significantly mortality and morbidity. And maybe play with the other drugs in order to give room for that little bit of blood pressure.
Final word from you before we give the word to Sabine to wrap up.
I couldn't agree more. That's what we would have done. But as said, we thought it's not even worth changing too much, but do the procedure and optimize GDMT at the same hospital stay.
Sabine, what did we learn today?
So I would say I learned so much about how the synergy between drugs and interventional treatments can work. And to summarize the key messages, I have to say when available pharmacologic options are not actionable for patients' hemodynamic conditions, consider interventional strategies. The transcatheter edge-to-edge therapy is a safe and very effective strategy, can even reduce the MR to surgical-like results, and not only to reduce functional MR, but also to optimize and then up-titrate GDMTs. And yet after MTIR, get back to the clinics, maximize GDMTs through any intensive monitoring and follow-up. And if you like to learn more about these concepts and the iHF, visit our annual course. The first one will take place 20th and 21st March 2026 in Madrid, in Spain. You can find all information about that on the website, iHeartFunction.com. And we would also be happy if you follow us on the social media. And thanks to everybody for watching us.